So I think nice to see Alam, by the way. So when Alam, Hanan and I started out, really, we were really in the dark. We used to see people with throat symptoms, and the only serious question was, did they have throat cancer or not? So, you know, in my day, use a mirror, in Alan's day, a poor quality endoscope, and check they didn't have cancer. And if they didn't have cancer, then they were either dispatched back to the GP, telling them not to worry anymore, or if you were very enlightened, you'd send them off to a speech therapist. But then we all saw the light. LPR came along, and thank God. So suddenly we had something else that we could hang all throat symptoms on. It wasn't just cancer or nothing. We could have LPR instead. And this spread like wildfire. This is Jamie Kaufman in her later iteration as a lady in New York. But in her earlier iteration, she did her PhD on looking at extraesophageal reflux in dogs and coined the term laryngopharyngeal reflux, and then set about throughout the 90s and noughties, spreading the concept of LPR with religious zeal. And it took hold because it was very fertile ground. We literally had no scientific basis for what we were doing. But increasingly, it's been shown to be an element of emperor's new clothes. So the problem is that we don't understand the pathological basis of throat symptoms. And we really don't. And there is so much more science that needs to go on. We need to understand the way the muscles work, the physiology, the sensory receptors, and I think particularly the microbiome mucosal immunology interface. And I think that's probably true for a lot of GI as well. So we are still working pretty much in the dark, but we're getting a few clues about what to do. So I'm an ENT surgeon at UCL, UCH, and at what used to be the Royal National Throat, Nose and Ear Hospital, but which is now this nice shiny new facility, which is on Huntley Street next to the main building. And I specialize in throat, so I do voice, swallowing, breathing problems, and rehabilitation of cancer patients. Declarations there, so well, anyway, they are what they are, and so I'm not doing much at the moment. But if I'm open to offers, I'm actually open to offers. So what we're dealing with here, globus pharyngeus, formerly globus hystericus. Of course, globus hystericus, deeply sexist term. Men can't be hysterical because we don't have wombs. Of course, my wife would disagree. And the inflamed larynx. So this is a really inflamed larynx, and it's got big polyp at the front. It's got loads of swelling in the ventricle area between the true vocal cord and the false vocal cord. The whole larynx is edematous. So in a patient where you saw this and they were getting rip-roaring heartburn and regurgitation, there would literally be no real problem. But unfortunately, we rarely have that situation. So symptoms, this is Janet Wilson, who we heard about earlier from Jason, and she's been the ENT guru and has set about Jamie Kaufman's hypothesis that everything's reflux. And there have been the most amazing debates between Jamie and Janet, because she is about 6'3" and incredibly extrovert, and she's about 3'4" and Glaswegian, and it's a fantastic battle, actually, which I have to say she's pretty much won, because there's very little evidence that everything in the throat is due to reflux. About 25% of the UK population gets some throat symptoms. We heard some higher figures than that from Jason earlier. There's a very strong placebo response. Janet did some elegant studies looking at how much psychological involvement there was in development of globus pharyngeus, a feeling of a lump in the throat, throat clearing, discomfort, postnasal drip, all of those kind of symptoms, and really found no big difference in a group of women who were tested psychologically with globus compared to those who did not have globus. There's never been a large RCT showing benefit of PPI over placebo, but the Toppitz trial, which again Jason alluded to and is about to be published, showed no real benefit over PPI over placebo. However, although this is an extremely laudable trial and adds significantly to the evidence base, I have to point out that there was no objective testing of whether people actually had reflux or not in this trial. That would have been, quite a logistic exercise to do dual probe and OGDs on everybody, but that was absent from this, and it was purely symptom based. So I think there is still a question, and there's undoubtedly Globus patients who do benefit from treating reflux. Also an association with cough, and I think we'll be hearing a little bit more about that later on. I prefer the term extraesophageal reflux because it's not just the larynx, it's also the pharynx and the back of the mouth and the lungs as well that can be affected. Measurement of exposure, so symptoms could be direct, but a lot of them could be referred. There is, as presumably we'll hear again later on, the concept of reflux stimulating those sensory receptors that Phil Woodland showed us earlier that are so close to the surface, lower in the esophagus, and stimulating reflexes higher up in the aerodigestive tract. 50% of people with no Globus symptoms have episodes of pH less than 4 above the upper esophageal sphincter on dual probe monitoring. Throat patients have more recorded pH drops. So people with Globus have more recorded pH drops. But as Anthony pointed out, there's yet no international agreement as to the interpretation of the top part of the upper GI physiology studies and Globus diagnosis. Pepsin, there is definite evidence for pepsin in the larynx and pharynx. This is, as you know, extremely aggressive enzyme, and the laryngeal mucosa is very sensitive. And so the concept is that even very small episodes, brief episodes of reflux, will stimulate any nascent pepsin and cause damage that way. As we've been hearing again from Anthony, aerosol and impedance been a bit less work, and the true meaning of rest tech we've been hearing about. And associations don't equal a causation, of course. We use a tool called the Reflux Finding Score, which was developed by Peter Belawski, who's a laryngologist in California. And he developed it when he was working as Jamie Kaufman's resident, in fact. He also developed something called the Reflux Symptom Index, which we've heard about earlier. And these in combination have been used as general markers of whether ENT patients have reflux or not. They are very, very general. The Reflux Symptom Index, Peter now accepts that it's a general indicator of throat health and is not really terribly specific for reflux. And the Reflux Finding Score is extremely observer dependent. This is a points-based scoring system where you look at the larynx with a nasendoscope and look at various factors and then score them. I do use it, but it's really in the absence of anything else. And it allows me, I mean, I know what my scores are. I wouldn't necessarily say they're going to be exactly the same as everybody else's. And there are abnormal reflux finding scores in 64 to 86% of people, depending on how you look at it. And in those with Globus, 38 to 50. So as you can see, it's a mess. The observer-based scores and the symptom-based scoring are really messy. There is a suggestion that Pseudo-sulcus is the best predictor, and I'll show you that in a second. And I do look for that specifically. But really, reflux finding score, like the symptom index, probably represents a generic measure of mucosal health rather than being specific for reflux per se. And the use of PPI, obviously, tends to be mandated by GI symptoms, really. So this is a nasendoscopic view of the larynx. We've got vocal cords, so the right vocal cord on the left of the picture and left one on the right. And here you can see the edge of the vocal cord is not really very clear cut. In fact, it almost looks as though there's two true vocal cords, one below the other, with a groove in between. And this is called Pseudo-sulcus vocalis. And the theory here is that pepsin and reflux cause subglottic inflammation with this effect. This patient also has a rather boggy posterior commissure, so the area between the vocal cords at the back of the triangle is a bit boggy as well. But that's really very poorly correlated. We did a study with Wisconsin which showed that actually what's called posterior laryngitis by some people, which is sometimes used as a synonym for LPR, actually is pretty non-specific. and I prefer the Pseudo-sulcus. Problem is that Pseudo-sulcus also occurs in this condition, and this is presbypharyngis. It's an old throat, basically. In old throats, the thyroarytenoid muscle, which is on the side of the vocal cord, wastes, and then the vocal cord appears to be thinner and smaller. It's not. It just moves to one side because the muscles are weaker, and that reveals the subglottis and gives you this Pseudo-sulcus appearance. We can see the windpipe going down there. We can also see in this elderly patient how wasted all the pharyngeal muscles are around it. So it's no wonder that these people aspirate, and it's been measured that in people over 70, something like 30% of swallows involve some element of aspiration. So transnasal esophagoscopy has been alluded to earlier, and this has been around for a long time, but it is increasing in use. It's not found its place properly in the UK because it's a relatively expensive setup, and there is a learning curve. Really, when I use it as a screening tool. It's really handy to have it in the clinic. So if a patient comes in with Globus symptoms, it's really a long nose endoscope, and I can very quickly check for some of the more gross esophageal disorders. This does not replace the need for OGD in people who have suspected reflux and other issues. And my mantra to any ENTs who are learning TNO is to have an incredibly low threshold for referring on to GI, and even take images and same day share them with your GI colleagues from clinic if you're not sure. So we've got a very low threshold for that, but it is really quick, and it's nice to be able to more or less rule out esophageal cancer and rip-roaring esophagitis. But we can also look for some other stuff as well, and this is one of Jason's gastric inlet patches with using the iScan facility on my Pentax system, but NBI will do also. And it's quite nice to be able to do that in the clinic as well, in the sitting up patient under local. TNO takes about 7 minutes to do in total. And you can use TNO to do stuff with as well. So I can use it to do balloon dilatation in the clinic. More commonly, I do this under mild sedation in theatre. It's just logistically a lot easier to do that. This is double balloon dilatation going on here. So this is for patients with resilient tightness of the cricopharyngeus. Cricopharyngeus is actually kidney shaped. It's not round, but we don't have kidney shaped balloons. And so it's sometimes helpful to dilate with two balloons in parallel. This is pretty uncomfortable without sedation, I have to say. One balloon can be tolerated, but not always two. And it's very safe. There's only been one reported perforation in the world literature for TNO, and my nosebleed rate is about 1%, and it's really very minor. So, okay, treatment, PPIs. We've been hearing from Phil, and I cannot add to his masterly discussion of the medications. The studies for the throat, however, are not uniform and inconclusive to a large extent. And the presence of heartburn in selecting patients for Globus trials really does confound things quite a lot. Alginates have been effective in one RCT, and I was very pleased to hear some of the advances in alginates from Phil. And then there are issues over weaning all the people once we've decided actually it's not reflux after all, and the very, very minor side effect issue. And then we've also heard about the evolving picture for the role of lower esophageal sphincter surgery and stretta as well, which we've already heard about. So this is critical. So I do my clinics in association with speech and swallowing therapists. These are highly specialized speech therapists who do voice and swallowing. Swallowing therapy is actually poorly developed in the UK, as is dysphagia management as a whole, in fact. That's one of my big bugbears, really, how we really need to pull that together. They're indispensable because whether or not there are elements of reflux, there are almost always elements of muscle tension, and you can feel this in the throat. So if you move the larynx from side to side in a Globus patient, you can feel crepitus. The larynx is being held rigid, it doesn't elevate properly, and it's pressed back against the pharynx and against the prevertebral tissues, and you can crackle it against the back. The hyoid bone can become very tender and sensitive, and the whole thing doesn't elevate properly when you swallow. So the muscles externally become very tense as well as the ones inside. And speech and swallowing therapists can work with patients dealing with some of the psychological issues as well as some of the physical issues. There are exercises which will allow them just to relax the inside, as well as massage therapies that will help relax the outside. These days, of course, we do an awful lot of this, and most speech, well, actually, it's mandatory now that speech therapy starts with remote consultations. There are very few speech therapists still seeing patients in the NHS or even privately at the moment, which is a shame because actually the personal contact is critical where there's big psychological impact, and also for the massage therapy. I've heard from gastroenterologists and GI surgeons that they find it difficult to find an interested voice therapist locally or in their NHS clinics. You can find a guide to this in the British Voice Association website, and you should be able to find a voice clinic close to you with an interested voice therapist. And if you are in London or London area, I'm happy to guide you as to who are the best. There are some who are absolutely brilliant for difficult dysphasias, and some who are really, really good at the more psychological side of things. So symptoms, cough, globus, we think they represent a default response to all kinds of challenges, of which reflux is only one. And of course that stands to reason, but this is a big shift away from where we were in 2005, where basically you managed everybody with as though they were LPR, and then moved on if they didn't get any better. So I'm going to actually ask you whether you think these people have had reflux or not. So this is Josh Stone. She is a soul singer, and she had these things, vocal nodules. Kinesh, did Josh Stone have reflux? This is very unfair. I'm catching people completely off guard here.
Kinesh might have to get out of his hot tub first.
I think you're right. Okay. Alan, you're ENT, so this is cheating a bit. This is a really good test of how many people are actually listening to my talk.
I'm gonna butt in here because my interest in Joss Stone is twofold. I think she's very good, but also she's from Dover, which is where I'm from, and I don't think anyone from Dover can have functional symptoms.
Can I just say, I think everybody from Dover has got functional symptoms.
Well, yeah, and so is she where Dover Soul comes from then, Phil?
What, the sea? Yeah.
Soul. Anyway, never mind. Anyway, so there, yeah. So she famously said that. Hang on, there we go. I've got nodules on my vocal cords. Oh, hang on, there's the next one. Actually, I wish certain people would realise that I need time off occasionally. I think we all sympathise with that. So there is some evidence of an association between vocal nodules and reflux, and it may be that people clear their throat a lot more. These are classic nodules associated with vocal abuse or overuse. The management of these is speech therapy, but if you are going to operate on the larynx for anything at all, I always cover my patients with PPIs as well for a week beforehand and 2 weeks afterwards, just to make sure that we don't get any acid or pepsin on my beautiful little wounds. Okay, Nick, hopefully you're still listening. That's Nick Boyle, by the way. What about Bill Clinton? Reflux, yes or no?
What sort of gastroesophageal reflux or ejaculatory reflux? I've no idea. Probably, I think he did. Well, his wife did, didn't she? His wife did, I think, during the last presidential election campaign. Is that right?
Yeah, kind of. So the right answer is that he did have actual gastroesophageal reflux and was being managed conservatively for good. And then one day he developed severe burning in his throat that radiating down to his chest. And in fact, it turned out he was having an MI. And subsequently, his voice has actually got a lot worse since he had his triple bypass. So here is what Jamie Kaufman said. Bill Clinton may have had either vocal cord damage during surgery or acid reflux could also cause it. He's got a very breathy voice. Well, actually, I know, Jamie, we do love you very much, but this wasn't reflux. This was actually vocal cord damage, in fact. But you're right. Her voice famously broke up quite a lot. during the last presidential campaign. She simply couldn't believe Donald Trump, and we're still there, aren't we, really? And actually, there was no evidence that she had reflux. Her voice was breaking up for psychological reasons, in fact. Okay, what about this guy? Who should we ask? Bobby, are you listening? Bobby Prasad. This is fantastic. Everybody's gone off to have a cup of tea. Okay, Anthony, come on.
I can hear you. Sorry, I pressed the wrong mute button.
Oh, no worries. Okay, Bobby, what do you reckon?
So, I mean, he had a lot of he had what do you call it? Sort of HPV related issues, didn't he? So, a lot of oral sex. So, I'm afraid I don't know, but I'm going to say yes, he did.
Well, so there's been no evidence that he did, in fact, but you're quite right. He did have throat cancer. I think we're okay, actually. Hopefully there's no children watching and Anthony's hiding his dogs, because this is what he said about his throat symptoms. Without wanting to get too specific, this particular cancer is caused by HIV, which actually comes about from something which I'm not going to say. I think that's reasonably specific, actually. There is actually evidence that reflux does contribute to throat cancer. It's probably, the relative risk is something like 3 times increased relative risk, which is quite significant. But a lot of people with throat cancer still have really bad lifestyles, and unpicking that is difficult. However, our guys now do TNOs when they're screening people, doing panendoscopies to make sure there's no synchronous tumours, but also looking for reflux as well in all of our head and neck cancer patients. Okay, well, right, Stephen Fry. Who should we ask? Who wants to know about Stephen Fry? Jason, are you still there, or have you run away? It'd be within his limits to run away. I don't know Shameen, actually. What do you think, Shameen? Shameen Jonu?
I'm not sure, actually. I wasn't aware that Stephen Fry had problems with his voice or reflux, so I plead ignorance here, I'm afraid.
Yeah, well, actually, he regularly tweets his PPI dose. In fact, he's a big enthusiast for PPIs, and believe that that's helped him with everything. But on one famous occasion, he also tweeted this. Awoke with satanically painful sinusitis, wanted to wrench my left eye out, work Sudafed. So there is a whole penumbra about whether sinusitis can be associated with reflux as well. In fact, there is no evidence that sinusitis per se is associated with it, but there is some evidence that there is an esophago-nasal reflex, and that when you're getting reflux, you are more likely to get nasal obstruction. But I don't think that his sinusitis was in fact related to his very well publicized reflux. And finally, this is another baby. I did try and find a famous baby that had glue ear. And that's glue ear for you. So Rishi Singhal. Rishi, what do you think about glue ear and reflux?
I'm not sure. I mean, babies. I mean, babies do have some kind of reflux. If I can remember from my pediatric days, babies do get reflux. But is that related to glue ear? I'm not sure. I'm sorry, I'm not sure.
And I think you're right to be not sure. It's a relatively unclear picture. However, gastric type pepsin has been isolated consistently from the aspirate of babies undergoing grommet insertion for glue ear. So there is some connection there. They are, of course, lying on their backs a lot of the time. They're regularly refluxing, and they're very patent eustachian tubes. So actually, perhaps it's not so surprising. But in terms of a causal link, I think I'm somewhat doubtful. But there we go. There's reflux going up the eustachian tubes. Okay, so We have started a dialogue, the British Laryngology Association and the BSG, about trying to unify our approach nationally and guidance to LPR, globus and dysphagia. The BSG, as you know, has a long-established esophageal committee, and they published some views on the throat in gastroenterology in 2017. We held an initial meeting with them in the middle of last year and a subgroup meeting in October last year. But unfortunately, because of COVID, we've actually not progressed any further. We would actually really like to work more closely. So this is something published by Harvey in Frontline Gastroenterology in 2018, and it's a kind of simple flowchart, which I suppose is quite useful for GPs, although I think any of us really drilling down into this would probably find some issues. I mean, for example, I would say that just because people have an abnormal laryngoscopy, it doesn't mean that there's not more than one thing going on. So they can have multiple things going on, and they usually do. They usually do need a bit of speech therapy and a bit of hands-on. They usually do need a bit of attention to their psychological side, as well as a serious consideration about whether they've got reflux or not. And I have to say, I've got quite a low threshold for referring for OGD and pH impedance studies. Maybe that's because I've got a slightly tertiary practice and I'm getting more resilient patients. But you know, a lot of people don't want to be taking medication unnecessarily, and I think if we had a easier access to GI physiology, then we'd probably send a lot more, I think. On the cancer side, obviously alarm signals should go down the 2-week wait anyway. There's a rather inflammatory paper, I think, that's going to come out soon, which is from an ENT surgeon on the South Coast, that's going to suggest that gastroenterologists miss more head and neck cancers than ENT surgeons miss esophageal cancers. I think, however, he misses the point that ENT surgeons also miss quite a lot of head and neck cancers as well. So don't get too excited when you see that paper. Okay, key points then. So a lot of people are getting upper aerodigestive symptoms, which could be ascribed to reflux. They present to multiple specialties, and we've got many of them presented here today. We don't understand the pathological basis of throat symptoms. I think we're still in the dark age. My son, who did philosophy, describes us as being at the we are ants stage. So we think we know so much, but actually looking back in 50 or 100 years' time, we're going to look pretty ant-like, I think, when it comes to the globus. Reflux has been a convenient catch-all, but you know, we need to be far more selective. Of course, we all need to work together. ENT, GI surgery, respiratory medicine, speech and swallowing therapy. Thank you very much.
Great, that's great, Martin. I've got a few questions. First question is from Bill Clinton's defense lawyer over in Leeds, Simon Dexter, saying, was the white stain Gaviscon after all?
Yeah, it was. You have to be really careful taking the top off the bottle, actually, when you're otherwise engaged.
Okay, so I've got two questions from Majid. He first of all is interested to hear if Martin has an algorithm for the investigation of sore tongue or burning tongue as the predominant symptom. Same as LPR, and does a blood test have any role?
Oh, okay. So
you can just say no.
No, actually, my algorithm is to send them to the Eastman Dental Hospital straight away. Yeah. So yeah, I know. Yeah, it's a heart sink symptom of burning tongue, and you know there's actually. Well, I'm very fortunate. One room away from me is the throat pain and burning tongue clinic, so it's very easy for me to bounce them along. Yeah, I mean, you know, there's a whole load of blood tests you can do for immune deficiencies, for mineral deficiencies, and you need to make sure they've not got candidiasis, that it's not secondary to drugs that they're using. But you know, 98% of the time, there's a big psychological component to it, and they need appropriate laying on of hands.
Okay, so moving on, I have got 2 questions on PND. So the first one's from Andrew. Can you tell us your views about occult PND in patients with throat symptoms in those seeing GI and those seeing ENT?
Yeah, absolutely. PND. This is really interesting because, again, when I were a lad, 50% of the people coming through clinic had PND and were referred with it. But it's just fallen out of favour. GPs don't refer with postnasal drip anymore. And patients don't pitch up saying they've got it a lot of the time. Maybe they do to GI, but it's certainly not something I specifically inquire about. The nose produces half a litre of mucus a day in normal people, and you produce up to 2 litres of saliva a day, and we just don't notice it. It all just goes down. If you have some reason why your throat is going to be more sensitive than usual, either for pathological reasons because it's inflamed, or because you have a hypersensitivity, a functional hypersensitivity or post-viral, then you're going to be more aware of it. And so the vast majority of the time, there is not an increased dripping of stuff coming down. It's really this hypersensitivity. And these are usually the people who've got a bit of globus and some other functional symptoms as well. People who've got rip-roaring rhinosinusitis are different. With them, if they've got clear signs of rhinitis and allergy, nasal blockage, pus coming out, that's a different story.
Okay, cool. So I've got a question here from Bobby about and this is something that I know is dear to Adam's heart here, that there was a paper in JAMA from 2017 that suggested Mediterranean diet and alkaline water was equivalent to PPI and LPR. Well, actually, I'd be very interested in your views on alkaline water. I don't personally prescribe it, but I have a lot of people coming in with it, and I don't dissuade them. So actually, it's definitely not my area of expertise. So yeah, I'd be very interested in other people's views, actually. Okay, so I live in Cambridge, and it's the most alkaline water I think ever, and I don't have LPR, so N equals 1, and it seems to work in me. I've got a question from Jordan about PEP test. Are there any other ways of non-invasive ways of looking at extraesophageal pepsin?
Well, we've discussed ResTech. It's not really non-invasive. It's much less invasive and rather better tolerated. Sometimes PEP test is definitely not 100% correlated with reflux, but it is very easy to do. And if you're trying to paint a picture, it's something that you can add into that. Again, patients tend to pitch up to me with their PEP test result rather than me requested. I think I've only requested like 2 in the past year. It's probably not as good as any of the things that we've been discussing today.
Okay, last question, 30 seconds. It's from Majid saying, if you want anti-reflux surgery in people who've got evidence of proximal reflux but distal negative pH in the absence of esophagitis, are you supportive of an anti-reflux approach in some of those patients, and what would push you into that decision-making?
Yeah, so I would be supportive. I would want to make absolutely sure that they hadn't responded to any of the other conservative measures that we've been talking about earlier. And you'd have to have a full and frank discussion with them about it, or rather Nick and the other surgical colleagues here would have to do so. They would have to be made aware that there is some evidence that it's going to help. And I would certainly not be averse to it. In a resilient patient where you've got that kind of picture on physiology testing, I would certainly invite them to have that kind of conversation about benefits and risks with my surgical colleagues. Yeah, I would.